I'm going to talk today on patients that present with movement disorders from the perspective of how I treat them as a dentist. I'm making no claims to making cures for these various diseases, but we can help them from a dental perspective very greatly by ameliorating or eliminating their symptoms. This is a 17-year-old high school track star that was in a motor vehicle accident in January 28th. She was rear-ended one evening. You will notice as the tape goes on that she has been to 33 other healthcare providers, including some of the most prestigious universities and hospitals in the Washington metropolitan area. She has been confined to a wheelchair and told that she would remain therein for the rest of her life. Notice the time. It is 2:37 on June 20th. We are inserting a mandibular orthotic for which we took the impressions of her lower jaw approximately 3 days previous to today. That was the first time we had seen her. We put this appliance in on June 20th. I measure her mouth opening and she can open approximately 20 millimeters. This was the one diagnostic feature that most previous healthcare professionals missed. Prior to inserting the appliance, I frequently do some osteopathic adjustments on the upper jaw to give the patient a running start in the response to their treatment. This is particularly true for post-orthodontic patients who have had constrictive type mechanics applied to their maxilla. By this I mean wearing a headgear, extractions, etc. This is an adjustment that loosens up all the facial bones if any of them are stuck or locked. We do that movement about 10 times. Okay, I have inserted her lower appliance and now I am in the process of adjusting it. Feel higher than the other? No. Sit here for a few minutes for that. Just tap up and down on it like that. That'll reset. I'm showing the patient here how much it strengthens her upper arm to convince her to wear the appliance all the time. It is an attempt to show her that the appliance will benefit her by increasing her upper body strength. Okay, let's see you get up and get your wheelchair. Leave it there. I want to see if you can get to it. Notice the time now. 1 hour has elapsed since the patient arrived at the office.
Okay. Excuse me? That is like the first time she's done this. So this is great. She can't do this without me. I know. Oh, shit. Are you happy? Yeah. Oh, man, that's great.
This is the first time she has walked or taken many steps in many months.
Thank you so much.
That's right.
Wait till Monday. The balloons are coming. See if you can stand up. Stand up, go ahead. See, she could not do that. She could not pull herself up at all.
Why don't you give him a hug?
Yeah, give him a hug. There you go, I know.
Notice when she gets up, she does not use the left hand or arm. She has lost the use of it. He's standing up for your daddy when he comes home tonight.
Oh, yeah, I know, I think we will. I think we will.
Oh, thank you so much.
Oh, wow. You just don't know what we've been through. So, thank you so much. Thank
That's
you.
what we do every day.
Okay.
Every day.
Okay.
The patient returns 4 days later without her wheelchair. I instruct her to walk around the office while we are working on other patients.
That's okay. Which chair do you want her in, Dr. Stone? Hold on. Come.
Notice she still does not use the left arm. We are going to insert her upper appliance today. This is it. It is a appliance made of stainless steel and gold called an alternative light force appliance. I am inserting it in the mouth to fit it, and in a few minutes after I adjust it, I will bond it in place. Director. Okay, you can let me just sit you up. You ready?
No.
This is the patient with the appliance fitted. Notice she's walking much better. We adjust it a little further. And each time we adjust it, she walks more freely. I am now adjusting the lower appliance to the upper so that they both fit in harmony with each other. I'm using carbon paper to detect any high spots on the lower appliance that putting in the upper appliance may have caused. And I just use a drill to rebalance the appliance so that it hits simultaneously in time and in pressure on both the left and the right sides. I usually do this 2 or 3 times. Here I am just showing the patient the improvement in her upper body strength. Notice she's starting to swing her left arm. Okay, just sit there. Okay.
So exciting.
Okay. The appliance is being bonded into place now. And her lower appliance is being readjusted. Notice the movement of her left arm. Actually, the movement returned within the hour of that appointment, but this is her on her 3-week return visit. Hi, how you doing? This is one of my first movement disorder patients. This was her appearance when she first appeared in my office. These are photos of her occlusion. The top photo gives you the amount of overbite that she has when she occludes her teeth together. This, to me, is a very deep bite. I do not want to see the upper incisors overlapping more than 20% of the distance of the lower incisors. In fact, I prefer less than that. On the lower left-hand side, she has a class 1 occlusion, and on your lower right-hand side, she has a class 2 occlusion. These are measurements of her range of motion. You can see that she has a 35 millimeter interincisal opening. This would lead you to believe that she has a unilateral or bilateral closed lock. However, you'll notice that she has a left click at 21 millimeters of opening and a right click at 25 millimeters of opening. This shows you that you cannot depend on clicking joints to determine whether they're reducing or non-reducing, because even closed lock joints, which this is a case, click too. The significant history that this patient gives was that she fell in an icy parking lot that was not sanded or salted, and there is a lawsuit involved. She has worn 2 hard upper plastic maxillary splints that she says did her no good. I have never used a maxillary upper splint. I cannot understand why other people use them. They say they stabilize the situation or stabilize the occlusion, but what they are really doing is stabilizing the disc out of place in its current position, so it never does improve. She now wears a soft maxillary splint that makes my face sore. The professional literature shows that these soft, suck-down, rubber-type splints cause increased muscle spasm, and I would not recommend using one. She was 1 month late being born. This is an indication of birth trauma, and her mother describes her face as being all torn up when she was born. She has inability to walk, and this was her big movement disorder. She's a newly married young lady, and she and her husband went out and bought a townhouse, and she can't navigate the stairs. She must crawl up the stairs of her townhouse due to severe vertigo. These are the tomographs of her left and right temporomandibular joints in centric occlusion. You can see at the bottom of the x-rays the teeth are together. And we use these films to evaluate the position of the condyle in the fossa, whether the condyle is anterior of center, posterior of center, or superiorized, inferiorized, etc. These are tomographs of the left and right temporomandibular joint in the mouth wide open position. You'll notice the condyle does not travel sufficiently on the left tomograph. It is supposed to travel past the eminence and be separated from it by 2 to 2.5 millimeters of space. which is the thickness of the disc. If one bone, the condyle, is touching the other bone, the eminence, you know there cannot be any disc interposed in between. The one on the right shows the 2.5 millimeter space occupied by the disc, which is in place in the wide open position on the right side. This is the patient that has been wearing the splint for approximately 2 years or so. She dropped out of my practice, and you can see that the splint has been added to by several layers, particularly on the left side. This is the patient occluding on the splint on the right side and occluding on the splint on the left side. She is asymptomatic and fully functional. When the splint is taken out of the mouth, this is her occlusion. She has a severe posterior open bite. This would really disturb most dentists that look at it because they do not know how to correct an open bite in the posterior. This is her occluding on the left side. Believe it or not, the discs are in place on both sides, and this is her true centric relation position, even though she has a posterior open bite. If you have done your job right, and the patient presented with their teeth together in the back, and you have fixed the problem, you will always, always, always have a posterior open bite. If you do not, you have not fixed the problem. Because in the treatment, you want the condyle to be inferiorized and the disc to go back on top of the condyle, and all of that requires space. And that's the reason for the posterior open bite. Now, believe it or not, this case is 75 or 80% done. You can look at this slide and you can see that not only are the discs in centric relation, but the midline is corrected, the overbite is corrected, the overjet is corrected, and all we have to do is make the little white things on the bottom touch the bigger white things on the top, and the case will be finished. These are the steps to treat this case. You have to tripod the occlusion front and back, either with second molar buildups or with a removable appliance, because you don't want the patient to overclose or to lose the treatment position that you have worked so hard to obtain. Then at the same appointment, bond or band, whatever you do, the maxillary arch and level and align it. Keep wearing the lower appliance at the same time. You insert a maxillary expansion appliance because the mandible has been moved forward, and you must expand the maxilla to accommodate an advanced mandible, or else the teeth go into crossbite in the buccal segments. Then when you're ready, you bond or band the lower arch, level and align them, and use extrusion mechanics to lift up the teeth in the lower buccal segments. This is the incisor buildups being applied to the maxillary central incisors. These are bonding material is used here to make lingual shelves. This is what it looks like when the bonding material is applied, and you can make these either flat or hollow ground them so the lower teeth fit into them like a keyway, or you can make them on a slanting upwards and forwards, so that when the lower teeth hits them, you have built in an anteriorizing interference. This is the expansion appliance that we used on this patient. The anterior and posterior expansion screws will expand the maxilla transversely. The left and right expansion screws will expand the maxilla anteroposteriorly. Another way to do this is to activate all 4 screws simultaneously and just expand out the maxilla at one time. This is what I usually do. This is what the maxillary expansion appliance looks like from the side. You can see the screws have been expanded at the top of the appliance for a considerable amount of time. You can see where it is tripoded in the posterior with these extensions that extend inferiorly, occluding on the lower second molars. This is the upper appliance seated in the roof of the mouth. You can see how it is festooned around the maxillary buildups, and the brackets have been placed on the teeth, And all of this has been done in one appointment. This is what it looks like at this time from the front, before we have put in the initial arch wires to approximate the teeth. The maxillary appliance is in. You can see the extensions in the left and right background, and it is maintaining our treatment position. Now the question should arise in your mind is, where do you establish the occlusal plane in the new treatment position? In other words, in this new maxillomandibular relationship, where are you going to occlude the teeth? There are three positions that are usually accepted. One is halfway between the occlusal surfaces of the incisors and the molars on the upper and lower arches. This is the edgewise technique, where you would extrude the upper teeth halfway down and extrude the lower teeth halfway up, and they would meet in the middle. The second technique would be to intrude the lower incisors all the way down to the level of the occlusal plane of the second bicuspid and first molars using utility arch wires. This is the bioprogressive technique popularized by Robert Ricketts. The technique I use is a constructed occlusal plane at the incisal edges of the lower mandibular incisors extending posteriorly without a curvus spee. In other words, I have this imaginary occlusal plane in my mind, and I extrude all the lower teeth up to it on each appointment. This gives maximum support to the overlying temporomandibular joints. This is a drawing of what it usually appears like when the patient presents for treatment initially in his initial symptomatic habitual occlusion with one or both discs at a place. The treatment position ends up looking like this. The mandible is advanced. It is in an ideal position with the upper incisors, and there is a left and right posterior open bite. The edgewise technique of putting the occlusal plane halfway between the upper and lower occlusions is illustrated in this drawing. The bioprogressive technique of using the occlusal plane of the lower first molar and the second bicuspid as a true occlusal plane and correcting everything down to this level is what the bioprogressive people use. What I use is an imaginary occlusal plane from the incisal edge of the lower incisors extending all the way back through the second molar without a curvus spee, and I elevate all the teeth in the lower buccal segments up to this occlusal plane. And this is what we're going to be doing on this patient. I'm going to show you how to do it with just 5 arch wires in this case. The initial arch wire is a lower Twistaflex wire that is very flexible and goes through all the teeth. Nowadays we would use a titanium arch wire or a nickel titanium arch wire to do this. The second wire is an 016 multi-loop stainless steel wire, the multi-loops providing flexibility of the arch wire and making it more gentle. Make sure the horizontal portion of the boot loops are extending towards the depressed teeth. This gives you maximum mechanical advantage. This is the same wire from the front. This is the next wire on the lower arch without the loops. It is a continuous stainless steel arch wire, and you can see it from both sides with the maxillary expansion appliance in place. What we are doing is closing the spaces now with elastic thread. The teeth are touching each other, and you can see they are doing so without over-rotating or over-closing the mandible, because the overbite is not increasing. In fact, the overbite is 0, edge to edge, and the teeth are in contact on the buccal segments. This is it from the left side, which is the 4th arch wire, which is a 1616 stainless steel arch wire on both the upper and the lower. This is the case debanded, and you can see that the teeth in the lower buccal segments are in contact. The teeth themselves have been extruded. The alveolar tissue has been extruded. The crestal bone has been extruded. And all of it comes up together if you do this properly. This is it from the right side in centric occlusion, and this is the right side with cuspid guidance, showing you that there is disclusion of the teeth. This is a composite of the right side showing centric occlusion on the upper left and cuspid guidance on the lower right. This is centric occlusion on the left side showing good interdigitation of the teeth and cuspid disclusion on the left side. This is a composite showing both the centric occlusion on the upper left corner and cuspid disclusion on the lower right corner. This is the before and after, and it probably took about 18 months to go from the before picture on your left to the after picture on your right. This is the right side. This is the left side showing her when we started, stage 2, and centric occlusion on the right side. And again, I want to emphasize this only took 5 arch wires and approximately 18 months in time. This is centric occlusion on the top photo in both centric occlusion and centric relation. And this is the protrusive excursion on the bottom slide. This was her before treatment when she started, and you can see the amount of overbite correction comparing the upper photo to the lower photo. This is the patient. In other words, we not only straighten their teeth, but we reconstitute their whole wellness. You can see how she was on the left, and if you don't realize this is a sick patient with an internal derangement, you will correct her teeth to the internal derangement. But if you correct the internal derangement first and make her fully functional and asymptomatic, you get the patient on the right. And then if you interdigitate the teeth right and stabilize her in this condition, you have set her up for the rest of her life. This is her showing the amount of interincisal function she has at the end of treatment. We want 48 to 52 millimeters interincisally on an adult, and if it happens to be a child, 54 millimeters. Do not think of children as little adults who can't do things as good. Think of children as people with shallower glenoid fossils, looser ligaments, looser capsules, that can do things in excess of an adult. This is another early movement disorder patient. Frequently when a patient has one thing wrong with them, they have several things wrong with them. And as you can see, when this patient opened his mouth, his tongue was at a slant, as if the nerve to one side of the tongue was not working. Recall your anatomy if you can and identify what nerve this is. It is the left hypoglossal nerve, number 12. He has right frontal headaches, and this is his occlusion. You can see from the front the amount of overbite and overjet he has. This is the right side on the left side of the screen, and the left side of his occlusion on the right side of the screen. You can see his overjet is increasing, and he's creating an anterior open bite. Basically, this is a relapsing orthodontic case. When you see protrusive maxillary incisors, an anterior open bite, an increased buccal overjet, and antigonial notching, which you would look for on your Panorex X-ray, suspect an internal derangement with degenerative joint disease on one or both sides. This is his range of motion measurements, and you can see he opens straight up and down until 42 millimeters, and then he deviates away from the midline and then back to it and ends up opening at 55 millimeters. You'll only pick up these deviations if you have him open his mouth very, very slowly. He can move his mandible laterally to the left and to the right, only 5 millimeters in each direction. Normal is 12 millimeters. 12 millimeters is merely a half an inch. If a patient can't move his mandible a half an inch to the left or a half an inch to the right, you should suspect that something is wrong. When we palpate around his head in all the structures, no muscles were in spasm. Why would there be no muscles in spasm? Usually there are. The reason is he's a flaccid paralytic, and the muscles don't work correctly. None of them are in spasm on the examination. This is his history that he gives of his symptoms. Migraine headaches, much neurological testing. His medical file, he states, is several inches thick. He has trouble walking, and which most of these movement disorder patients do have. He has mental confusion, can't remember anything. He's been classified as learning disabled since very early childhood. He's had orthodontics from 14 to 16 years of age, which is relapsing. He's had 4 bicuspid extractions. He's had cervical headgear, and his maxilla is over-retracted due to wearing the cervical headgear. This is his cephalometric X-ray showing the antigonial notching in front of the gonial angle. He also has a constricted airway, which you can see posterior to his palate. His frontal X-ray shows occlusion of the nasal fossa with overgrown turbinates. So therefore, this patient has 4 strikes against him: an obstructed nasal airway, an obstructed pharyngeal airway, which you saw in the previous slide, C-spine degeneration from the previous slide, and a non-functional hypoglossal nerve. His left condyle is supposed to be nice and round, about the size of a dime, and you can see it's bent forward and comes to a point. His right condyle is flattened off and comes to an osteophytic point on the anterior superior surface. Here is a close-up of the right side in centric occlusion. This is not a normal condyle. You can see its outline here, coming to a point and then back. This is the left side, wide open, which you would suspect at 55 millimeters interincisal opening, where the condyle has come past the eminence right here and is separated from it. This is his occlusion from the right side, showing that the orthodontic result is relapsing. This is the occlusion on the left side. It's a little better, but still relapsing. This is the splint that the patient was wearing when he presented to my office. It's a little teeny-weeny splint that people make to put on the back teeth to eliminate interferences, because they think interferences cause muscle engrams, which causes the pain. As you can see, it wouldn't do a bit of good in this patient's case. It's very harmful, in fact, because it's the wrong design. You put that little splint in his mouth, and his mandible goes posteriorly, increasing his anterior overjet, or protrusion of his teeth. When you take it out of his mouth, the protrusion of his teeth lessens, so the splint is causing him harm and making him worse by posteriorizing his mandible. On the left side, you can see the harmful version of the splint posteriorizing his mandible, worsening his osteoarthritic degenerative problem. On the photo on the right, without any splint, the patient's body repositions the mandible downward and forward, decompressing the tissues of both joints. This is the repositioning splint we used. It is a highly indexed splint where the patient can bite in only one position. This is what it looks like out of the mouth. Here he is opening 54 millimeters, and you can see his tongue is already getting better on his left side. This is the patient at the end of treatment, and you can see his mandible has been repositioned in an end-to-end position. This is centric relation with the disc in place. And now the second stage, and there is always a second stage to address the occlusion of the teeth, is fitting the teeth together on the sides. We do this again with the maxillary expansion appliance to accommodate an advanced mandible, put teeth on the upper arch, and level and align the teeth. On the lower arch, we put composite buildups and brackets on the rest of the teeth and level and align them. We put a molar tube on the second molars as high up as we can even if it's on the composite buildup. This is the patient at the end of stage 2 orthodontic treatment. Can you see a difference in his tongue now? When you correct one thing, usually the other things that he has wrong with him self-correct. This was him before and after. You can see the difference in his tongue right away. This is his condyle at the end of treatment. If you remember how it was originally, it is more substantial and bulked up now. This was it originally, and see how thin and narrow and tapered it was at the end? This is a comparison before and after. The condyle is much more massive now than before. This is the right condyle after treatment, showing that it too has changed shape. This is the right condyle before treatment, showing how flattened it was at the top and coming to a point on the front. This is the before and the after of the left and the right sides. You can also see that the glenoid fossa has more definition, the eminence has more definition, the condyle is bigger. Everything is better afterwards than before. When making tracings of the left and right sides before and after treatment, and superimposing them on the intervascular bundles on each side, we can look up and see the increase in height in the condyles, and it has increased approximately 3 to 4 millimeters on each side, at least 3 millimeters on the left, and possibly that much or more on the right. Okay, this is his left side wide open before on the left side, and afterwards on the left side. And the right side is before on the left and after on the right. This is the patient as he came in 6 years post-treatment. You can see the improvement in his tongue is holding, the inner incisal opening is holding, everything has been stabilized at this improved position, and he is now off welfare and working and is contributing to society. These were the x-rays that we took at that time, 6 years post-treatment, and you can see the improvement in the condyles are continuing to hold. The take-home message from this patient is that only anterior repositioning appliances are capable of making these changes, and they are capable because they mimic normal mandibular growth. This is the anterior repositioning appliance. This is normal mandibular growth where the weight of the mandible distracts it from the base of the skull, and it tends to grow back in the direction the arrows are pointing. Parkinson's disease is due to decreased dopamine in the brain. The symptoms usually begin on one side of the body. It often begins with finger or hand tremor. There is slowed movement or decreased ability to move. The steps become shorter. There's difficulty getting up from a seated position. They have a stooped posture, balance problems, muscle rigidity and stiffness, decreased ability to blink, smile, or swing their arms, low, slurred, or hesitant speech, and handwriting changes that appear small and difficult. We're going to begin with this Parkinson's patient. She was first diagnosed with Parkinson's disease 13 years ago. Her main complaint is she cannot walk and her body, quote, freezes up. Her eyes water frequently. Another big problem is constipation and flatulence, which she describes as severe. Her left arm contracts uncontrollably with motor spasms. She's got loss of her right arm motor skills. She's got obsessive compulsive disorder and anxiety attacks. She can't concentrate and has difficulty speaking. She happens to be a nurse. She suffers from depression. Her body gets very hot. She has weird dreams, chronic fatigue, and insomnia. She has right back and hip pain. Current meds are levodopa, Mirapex, and sleeping pills. Her TMJ report, which we take on every one of these patients, shows her right disc is medially displaced. She has severe loss of equilibrium and vertigo problems. She has bilateral TMJ clicking upon mandibular protrusion and painful to chew, difficulty swallowing, stiff necks, cervical crepitus when she moves her head left and right, inability to turn head to the left or right, bilateral shoulder pain, tingling, and numbness. This is Rose, a patient who presents with Parkinson's disease. She has been seen by 3 or 4 neurologists, right?
Yes.
And you've been examined by Johns Hopkins University.
Yes.
And they've all diagnosed you with Parkinson's
That's correct.
disease. Tell the audience some of the symptoms you've had.
I have freezing when I'm walking. I have when the medication isn't working. I just can't walk across the room by myself. I have to hold on to things. I'm very weak and get fatigued. I have slow speech with just fine motor movement problems. Not able to wash my hair or brush my teeth or anything like that when the medication's not working. Little, very small writing where it's ineligible. It's not able to be read. Teary eyes. Not able to speak. My cognitive level I'm not able to actually function or focus on anything. Rigidity. My back is very rigid and sore. I get a lot of low back pain. Contractions, muscle spasms. My feet contract. My toes will crunch in and just flare out. Just a lot of spasms, muscle spasms, involuntary movement. I have some face pain too, facial pain, tingling in my shoulders.
How many years ago did this begin?
It's been about 13 years that it's all started.
13 years?
13 years ago. Yeah.
And what age were you at then?
About 47.
47, okay. And has it been getting worse over the past 13 years?
Well, the medication, and at first it just took all away my symptoms. I guess it's been really, the last 3 years it's just progressively getting worse. And then last year I actually had to take off work and go on disability.
So the medication is not as effective now. It's losing its effectiveness.
It's losing effectiveness. It doesn't, like yesterday, it didn't work at all for me. I mean, I was just off all day long.
We are delivering the appliance now and putting in articulating paper to determine if one side is higher than the other. The patient indicates that her left side is a little bit higher than her right side. Okay, just sit there for a while. This is Rose, our Parkinson patient, who's received her appliance 6 days ago and has been wearing it ever since the last 6 days. And I'm reviewing her symptoms that she came in with, and we'll go over them one by one. She'll tell you about her ability to walk, whether or not that's improved. Why don't you?
That has improved. I don't feel like I'm as off balance as I was before.
Okay, that's an improvement in her balance. And she was saying her toes would claw up.
My toes would claw up, and that is less than that. It's less. Usually I would have that every day, and now I think I've had like a couple of times since I've had the appliance in my mouth. Okay.
She was constantly constipated. And tell them what happened there.
Yeah, I was constipated awfully, and I know since I got the appliance, I've been going regularly every day now, which was never for me.
And what did you go before? Every 3 days, 4 days?
I go sometimes every 6 days.
Well,
and then I have to give myself an enema to actually, to be able to go.
Well, that's a big improvement.
That's a very big improvement. I was shocked.
Okay. And you had the loss of motor skills in your right arm and constant contraction of your left arm, and that's improved somewhat.
That's improved somewhat, yeah.
Okay. And your anxiety attacks that you used to have, how frequently did you used to have those?
I used to have them once in a while. I wouldn't frequently have them a lot. I would have them like maybe a couple times a month. But but I haven't felt depressed or anything this week.
No depression, okay. Weird dreams? You used to have weird dreams?
Still have some dreams, but they're not as horrible as they were before. They've been nice dreams, actually.
And depression?
I don't feel like I've been depressed all week.
Well, those are pretty good improvements for just 6 days into treatment.
Yeah, really.
What we're doing today is modifying her appliance to compensate for any wear that she's had in the 6 days, and we're increasing its height to take additional pressure off the base of her skull. And we're going to, her appliance is in the laboratory right now hardening up in a pressure cooker, and I'm going to go back and retrieve it and fit it to her mouth and polish it up and discharge her for the day, and that's going to be her entire appointment. Rose returns after wearing her appliance for 13 days. She's been wearing it constantly and has been experiencing good results. She reports that her constipation has disappeared and has gone from a bowel movement every 6 days to becoming regular, at least daily or at the most every other day. Her concentration is better. Her dreams have gone from weird to at least pleasant dreams. Her experiences with her body getting very hot have gotten better. Chronic fatigue is better. She gets more done during the day. Her depression is better. Her anxiety attacks are less frequent in spite of much stress at home. Why don't you comment to the viewing audience how the past 13 days have been?
Well, it's gradually gotten better. Before I had the appliance in, my medication that I take for the Parkinson's was not working. I had more off time than on time, which left me rigid and a lot of back pain, and that still a little bit. I get that with the medication, but not near as often. My balance is a little better. I have more on time with medication, meaning I don't have all the symptoms of Parkinson's that I did before. Depression's gotten much better, and like the doctor said, before my constipation was awful, I would have to give myself an enema to go. Now it's just like, it's changed. It's like more, just better, more frequent, and which makes me feel better. And all around, I'm just feeling a lot better. My fatigue's I have more energy during the day. I'm able to do things like before. I couldn't go to the store without being afraid that medication would stop working, and I'd be in the middle of a grocery store and just like be rigid and a lot of freezing, and I don't have that fear anymore because I'm feeling better. So it's amazing.
That's a good first report, and I'm pleased with the patient's progress. We are modifying her appliance today, increasing the vertical dimension of it, and we'll show you that as soon as it comes back from the laboratory. Okay. Chop, chop.
Yes, I tried mine.
Okay, bite. Open. Okay, bite again, bite. Open. Okay, you can stop. Okay, chop, chop. Okay, which side's high now? The right side. Chop, chop. Bite tight. Okay, the right's still high.
They're the same now.
They're both even? Okay, bite. Bite. Okay. Okay, this is the of the appliance that we are going to leave the patient with at the end of this appointment. And we'll see her in another week or 10 days and see what the improvement has been over and above what it already has been. Okay, this patient has returned. She's been wearing her lower appliance for 1 month and 5 days. We completely rebuilt it today, and this is the end of today's appointment. Overall, that you're doing
Better, definitely better.
This is this patient's frontal x-ray. You can notice that the mastoid processes of her temporal bone are not equally aligned. This one on the right side is caved in and closer to the midline than is the left. These temporal bones contain the glenoid fossas, so you can see that the glenoid fossas are not lined up symmetrically either. This is the probable reason why the disc on the right is picked up as being displaced by the MRI. You can also see that she has a deviated nasal septum right up here. Evaluate the nose for whether it's obstructed with overgrown turbinates or it has a nasal airway present. This is this patient's submental vertex x-ray. You can see that the mandible is not centered in the base of the skull, but is off to her left side. You can see the space between the right side of the mandible, which is right here, and the right side of her head, which is right here. And you can see that it is inset quite a distance, whereas on the other side, it almost is superimposed on the outside of her head. Also, you can see that this side of her head is more normally rounded than is this side, which has been flattened. All of these are cranial compensations to the displaced disc. This is this patient's Panorex x-ray. You can see that she is missing 4 third molars as well as 4 first bicuspids. This is in keeping with her history of having had 3 years of orthodontic treatment. This is the patient's lateral head x-ray. You can see she has a fairly substantial airway right in this area. This black shadow is her airway. You can see that she is suffering from suboccipital decompression of the tissues here at the base of the skull. There should be a 14 millimeter gap between the base of the skull and the first cervical vertebrae. This patient was diagnosed with dystonia and myoclonus. She's had migraines with aura all of her life, occurring all day long. She's had tension headaches up the back of her neck and head. Her whole body tremors and twitches. She's got bilateral arm numbness, left arm worse than the right, throat constriction, history of otalgia as a child. She's on medical disability leave since 2007. She also complains of headache with left face pain, photophobia, bilateral tinnitus. She complains of bilateral preauricular pain, left side worse than the right, bilateral arm numbness, left side worse than the right, bilateral TMJ crepitus, right side worse than the left. Her mouth locks shut, inability to move her mandible to the right, painful to chew food, difficulty swallowing, bilateral suboccipital pain, neck and shoulder pain. Her previous treatment consists of seeing 5 orthopedists or neurologists for back pain. She's had microdiscectomy and laminectomy. She's had chronic pain management, multiple nerve blocks and facet joint blocks. She's been to see 2 different headache specialists. She's had acupuncture and biofeedback. She's been to see a movement disorder specialist and multiple physical therapists, which she describes as 6 to 7. The medications she's on are Flexeril, atenolol, clonazepam, Scalaxin, Percocet, Maxalt, Seasonally, Zoloft, Dionex, and Lodine. These are tomographs through the patient's right temporomandibular joint in centric occlusion. You can see where the condyle is located posteriorly in the fossa. It should be at least centered in the fossa or slightly anterior center in the fossa. This is initial tooth contact, showing the position of the condyle in the fossa, and this is bite tight. You can see that the posterior joint space, or the behind the condyle, is diminished from the initial tooth contact to the clenched position. This means this patient has a distal skid from initial contact to bite tight. There is not supposed to be any distal skid. There should be no change in these two images in either the left or the right temporomandibular joint. So we can tell just by looking at the images that her occlusion is not correct. This is the patient's submental vertex X-ray, and you can see the mandible is not centered in the base of her skull. In fact, it appears a little bit cocked to one side. We take this view with the mouth wide open so we can image the first and second and sometimes the third cervical vertebrae of the patient. You can see that the lateral process of C1 lines up with the lingual cusp of the teeth in the upper arch on the right side, and on the left side it lines up with the buccal surfaces of the teeth, meaning the skull is either displaced to the patient's right or the cervical spine column is displaced to the patient's left. You can see that the foramina through which the nerves go are not aligned properly. You can see that this mastoid process on the patient's right side is much higher than on the left side. This is the initial appointment of a patient who comes to me with gait problems, meaning walking disabilities, and all the typical symptoms of a Tourette's patient. She also has the symptoms of a TMJ patient. You can see in this video she is using a cane. She also described to me that she uses a walker also when her condition worsens. You can see the MRIs of her on the view box in the background. We never, ever initiate treatment without MRIs on these patients. This is the very next day. What we wish to accomplish on this is a diagnostic workup, which means a bunch of very sophisticated tomographic x-rays through the temporomandibular joints, impressions, and possibly her splint delivery. She comes with all kinds of head movements, hand movements, foot movements, and pain. Notice the uncontrolled movements of her hands, feet, and head.
She's holding her head up. That's what I'm saying.
Okay.
Tell us what your symptoms are, so we can record it.
I feel really, really tense all through here, and I can't stop twitching, and my eyes blink like crazy. And it shakes, like the back of my skull almost, like shakes.
And how long has this been going on?
Long time.
Years? Or?
Well, I didn't shake like this. I just didn't have until I started screwing around with my mouth TMJ stuff, but I didn't have any motion in my neck, and I would get horrible neck pain and stuckness, like Torticollis thing, and migraines. Now those are getting better, but I twitch a lot. But if I'm not somehow supported, so I like put pillows under my arms and under my head and stuff, but raising my mouth seems to help stop twitching. I still get twitching sometimes, but not like this bad when I have something in my mouth. And opening it wide hurt.
Constant eye blinking and head twitching are cardinal signs of Tourette's syndrome. Pain upon opening or limited opening of the mouth are cardinal signs of internal derangement of the temporomandibular joint. Many times these patients will present with symptoms of both Tourette's and TMJ internal derangement. I have had the patient using tongue blades in her mouth to determine what the vertical dimension is, so that I know at what vertical dimension to construct the lower splint. At this point in time, I am delivering the lower splint for the first time. Okay. Well, let's see.
Yeah, there's one like there's a high back right over here, but otherwise it's much better like the left and the right side seem.
You like that, huh?
Yeah.
Sorry.
In here sometimes looks like it gets a little like
As I take the appliance in and out of her mouth, adjusting it each time, notice that when I insert the appliance, her head and facial movements and blinking greatly diminish. And then when I take it out for the adjustment, they return. And then when I put it back in the next time, they greatly diminish. You breathing better? Okay. Let's see you get up and walk. You think you can walk?
so okay. But I wasn't walking especially normal when I came in, just
Yeah, I didn't see you come in, but were you walking when you came in?
she was walking a little bit funny. This.
Okay, turn around and... Is that any better at all from when you came in or not?
I think it's a little bit better. I still feel like here, but I'm not. Well, it hurts just as much. I'm not quite as wobbly, I don't think.
Walk back over there. Many of these patients also suffer from low back or sacroiliac pain. This is due to sustained muscle contraction in this area. The patients invariably experience relief of these pains due to these appliances we make. We judge the effectiveness of the appliances by how they walk initially. Any improvement of the walk occurs in the first 2 or 3 minutes and then continues thereafter. And it gives us an idea of whether we're on the right track in the treatment of these patients. Believe it or not, this is an improvement in her walking. If you did not discern any noticeable difference, notice how her walking completely degenerates when I take the appliance out of her mouth. Not as good, is it?
I feel shakier.
Okay, I'm going to add to this. I have increased the vertical dimension 3 times, in fact, on this patient. You seem to get out of the chair a lot easier. Okay, turn around. Okay, let's leave it like this for today, and this should improve. Practice walking backwards at home, not particularly here. Do that like 5 or 10 or 20 times a day, 10 feet across your living room or something. And people seem to adapt to it, improve quicker with practicing walking backwards.
Okay.
And
Okay, this is the next day. Go ahead and tell us how you're feeling.
I'm feeling really well. Yesterday I went home and just napped for a little bit, and when I got up I could walk much better, more steady, and my low back pain was mostly gone. And I could do a little bit, like just leaning that little bit forward and back that normally kinks me up. I could do that, which was really good. And this morning I'm walking really well and sturdy. and my neck has calmed down. So, and I can actually like look up and down, which normally, makes me twitch a lot. So.
And no spasming.
No, if I take this out, it will spasm. But this is pretty good for me to be able to lift my head up that far.
Okay.
And I don't have any. I'm walking pretty evenly.
Okay.
So really good.
Good. Let's see. So your hands aren't shaking anymore.
Nope.
Let's see.
Nope. I can hold my head up by itself.
Okay, go ahead.
Keep in mind that these results were obtained within 24 hours of her initial appointment without the use of medications or psychological therapy to suppress her symptoms. We are trying to treat the prime cause of her symptoms, which will be revealed to you as we go through this DVD. Okay. Her opening has increased to 46 millimeters. Yesterday it was 41 millimeters. That's a 10% improvement, just like that. We're going to do a final adjustment and then send this young lady back to Cleveland. Jump shot. Okay. This is the final splint configuration. Okay.
Wonderful.
6 or 8 weeks, sweetie.
Yep, we got 6 weeks planned.
Okay.
Already in the book.
Good.
Thanks, you guys.
Bye.
Remember her initial appointment when you saw the MRIs hanging on the view box? These are MRIs through the left and right temporomandibular joints in both the closed and the open positions. The big question is, what did they reveal? Because you recall I told you that most of these patients were both Tourette's and internally deranged TM joint patients. And although we have addressed the Tourette's symptoms, it is not sufficient, in my mind, to do just symptomatic treatment. You have to address the prime cause of all the symptoms. It is now time to address the TMJ symptomology. The MRIs reveal that the discs within each joint were anteriorly dislocated without reduction. That means they were displaced to the front and did not go back into place upon opening of the mouth. This is why it hurt her to open and why her interincisal opening was limited. Although you may think 46 millimeters was a normal opening, to me it is an impairment of function. The normal opening should be 50 to 54 millimeters, in spite of what you may have been told by other people. So therefore, we now address the internal derangement, and we do this by open joint plication surgery. It has been my experience over the past 45 years that if you address only the symptoms without the TMJ dislocation, the treatment will have no stability and the symptoms will return within 1 to 3 months. Therefore, to provide long-term stability in the treatment of these cases, we must get the left and right displaced TMJ discs into their normal anatomical position in such a way that they stay there. And we do this through left and right open joint TMJ plication surgery. Those of you who are healthcare providers should know that it takes a very courageous patient to proceed with this step of TM joint surgery, because they have experienced such an improvement in their symptoms that they are afraid that they will risk losing this improvement if they go on to this additional treatment. To me, this is an irrational fear. It will only improve them if the surgery is done correctly. This is the patient 3 days post-surgically. She had a left and right open joint plication procedure. I've reviewed with the patient what her presenting symptomology was, and she's going to tell you the improvement.
I feel great. I'm surprised at how great I feel I can move without tremoring, and my back and my neck are not hurting. I can do the opening of my mouth without tremoring. When Dr. Stack was just measuring me and I, taking my appliance in and out, my head wasn't shaking, my arms weren't quivering, and I'm not in pain. I've been in pain for a very long time, so I don't even know how to explain it. It's really wonderful. Do you want some specific?
You had trouble walking, right?
I had a lot of trouble walking.
Okay, why don't you get up and walk out there and then back, and we'll just...
I can get up and down without using a cane or a walker, and I can walk
Okay, see that?
with a regular stride. I don't feel like my thighs are pulling on my back anymore, and I feel like and my neck isn't sore just like all the time. Usually it's hard for me to just hold my head up.
Okay, do it one more time up to that. Lay it back.
What's the difference likely to be when she's off medication?
Even better. Even better.
Be able to much better. Oops, if my chair's
Okay.
yeah.
Okay, we are rebalancing the patient's surgical splint to compensate for any spasm, muscle spasm, swelling, etc. And then we'll dismiss the patient and see her in the near future.
Right after surgery, I have been just amazingly better. I had, for the last 10 years, I've had pain, constant pain in my back, in my neck. I've had debilitating migraines. I have walked bent over funny. I tremored. My tremors got so bad that I couldn't stand right. I was using a cane. Sometimes I've been sleeping on and using a massage table. I haven't sat on a couch in like 10 years. I have been through every physical therapy, back surgery, steroid shots, pain blocks, everything, and nothing has worked. And the surgery, since I woke up from surgery, I could stand up, right up. I always used to have to push myself up with my arms, and I would be shaking. I couldn't look up in the air or to the side with my head, and I would blink like crazy, and my head would twitch to the left, and my husband would have to carry me around and get me up and down the stairs, or I couldn't go. I was homebound a lot. I couldn't drive a lot. I had trouble attending things, like just having trouble, going to my family's weddings and things. So I was very non-functional. And since the surgery, I can walk. It's not pulling on my back. I don't have constant back pain. I don't have constant neck pain. I stride normally. I have had no tremors at all. None in my hands, none when I'm moving, so I can move up all the way, and that would normally make my whole body tremor, and I can look to the side, and I can stand and sit without having any trouble with my back, without using my arms to hoist me, and I'm walking upright, so I'm going to be able to get stronger, because a lot of my muscles didn't work the right way. For so many years of compensating, so now I'm just working on strengthening and getting the proper muscles to work. But it's truly amazing. My family, my doctors can't believe it. They're so excited, and I feel happy. And they say I'm like I used to be. My face and my movement, and it's just so nice not to have constant pain all the time and feel like I can't even get around my own house. So. I don't need a walker. I've used a wheelchair, and I haven't used that or my cane or anything since surgery. And if anything to add, he hasn't had to carry me anywhere. So it's been wonderful. I'm really just excited to keep getting better.
After treating her with great symptomatic improvement, we recommended that she have bilateral TM joint surgery. The left TMJ disc was displaced with 40% of the disc anterior to the articular eminence. The disc was abnormally thin. The surgeon placed the disc in its normal anatomical position and sutured it in place. The right disc was displaced with 20% of the disc anterior to the articular eminence. The right disc was also significantly medially displaced, but in good condition. The disc was placed in its normal anatomical position and sutured in place. This is a Parkinson's patient who was diagnosed 14 years ago. She's been on Parkinson's medication for 13 years, and they are losing their effectiveness. It's been my experience that this is a very common happening after being on the medications for several years. She had a deep brain stimulator implanted 2 years ago, and she says it does no good because her physicians cannot find the proper settings. This is a very common thing that we hear from these patients. In fact, in the last month, we've had 3 or 4 patients come in with deep brain stimulators implanted that are not working. This is not an unusual occurrence for us. To complicate matters further, she was diagnosed with head and neck cancer 12 years ago. She was diagnosed and treated for TMJ problems 16 years ago and wore a mouthpiece for 3 years. We always take a CAT scan report on these patients. Always, always, always. And I've never seen a Parkinson's patient that did not have TM joint pathology. And we document each and every one of these patients with an MRI report. When they have a deep brain stimulator implanted, it's very difficult to obtain a MRI. And so we use a CAT scan, which is what we did on this patient. And the CAT scan report came back showing the following pathology: flattening of the rounded left condyle with erosions in the articular cortex, cortical erosions of the left articular eminence, narrowing of the left temporomandibular joint space, osteophytes on the anterior and posterior surfaces of the deformed left condyle, erosions of the right condyle, erosions of the right condyle's articular cortex and the right articular eminence, osteophytes on the anterior surface of the right condyle, narrowing of the left TM joint space. These changes are due to degenerative arthritis, worse on the left side. In examining the patient, we noticed that she had a deep bite of approximately 80%, which means that upper teeth extend down, covering 80% of the height of the lower teeth. Her mouth locks shut. She has difficulty swallowing and chewing, difficulty turning the head left or right, right neck pain, right shoulder pain, and insomnia. This is a Parkinson's patient who has had a deep brain stimulator implanted. You can see the wires running down the side of her head and down her neck to her chest. The deep brain stimulator does not work. No one has been able to find proper settings for it. Again, evaluate the cranial distortions present in this patient by the discrepancy in the positions of her mastoid processes here on the left side compared to the one on the right. This one is out and this one is in. Again, note her deviated nasal septum. This is the lateral head x-ray of this patient. You can see the wires from the deep brain stimulator running down her cervical spine into her chest. The only thing this woman has that is a real big asset for her is the size of her airway. This is a fantastically wide airway and will serve her well. This is this patient's submental vertex x-ray. It again shows the wires of the deep brain stimulator here and running down the side of her head, down her neck. It also indicates that she cannot extend her head posteriorly, because if she had normal extension of the head, the upper teeth right here would be at the top of the film, right up here. But this is the patient's best effort at extending her head, and you can tell just from the x-ray that she doesn't have normal extension. This is the patient's right temporomandibular joint images showing that there is no distal skid between initial contact and full occlusion. But notice that it shows an osteophyte on the anterior surface of the condyle right here. When they're pointed like that, that means they're made of osseous material as opposed to cartilaginous material. This is this patient's panorex x-ray, and I show it to you to show that frequently most dentists do not look in the TM joint area. But if you look closely, you can see that she has very narrow, if any, superior joint space on both sides of the film. That should immediately lead you to believe that this patient's mandible is malaligned and or a disc or both discs are out of place. These are two views of the right TM joint in the wide open position. You notice the lack of superior joint space right there. Notice the hollowing out of the posterior surface of the right condyle. Whenever you see something like that, suspect a space-occupying lesion applying pressure to the back of the condyle. This is a coronal view of the left and right condyles. You can see that the left condyle is eroded on the lateral surface here. This is a CAT scan image, not an MRI image, due to the strong magnetic field in the MRI running the risk of dislodging the metal parts of the deep brain stimulator. This is the right TM joint closed CAT scan showing a good image of the osteophyte on the anterior surface of the condyle. This is another coronal CAT scan of the left and right temporomandibular joints, and you can see what appears to be medial osteophytes also on both condyles. This patient who was diagnosed approximately 13 years ago. Give us a little bit about your history of this disease.
Well, at first, the first signs of it, I started to have a lot of trouble walking. I had a real stiff neck, and well, those were primarily the main symptoms. I had a very stiff neck for a while, and then I started having trouble walking. I couldn't swing my arms. When I was at work, I'd walk down the hall and I'd bump into the walls. I'd kind of have to use the wall to help me balance myself. I would start going forward and wouldn't be able to stop, and the same thing would happen. I'd just start going backwards and I couldn't stop either.
Okay.
I didn't have much of a tremor, but I do now as the medication's effectiveness is getting less.
Okay. The medications worked at first.
Yes, immediately. I took one pill and it was like I didn't have Parkinson's anymore.
And now it's 13 years later.
Yes.
And the medications aren't working.
No, I take it every 2 hours, and sometimes it works and sometimes it doesn't.
So they're losing their effectiveness.
Yes.
Yeah, okay. And then 5 months ago you had a deep brain stimulator put in.
Yes.
Yeah, tell us a little about that.
Well, it was a lot more involved in it than I had really expected, but I did get through it. You have to have the wires put in one surgery, and then about 2 weeks later, or I guess a week later, I had
battery pack put in my abdomen. And then you start going to the programmer for, for them to set the, I don't know what you call it, but the settings. They go like 1.8. Right now mine are both set at 2.2. But every time they've tried to put my settings up higher, I'll go home, and after a while I need to put it back to what it was before because it's just, I get stiffened so badly. And that's about how it's been so far.
Okay, so basically they haven't found the right settings for you yet.
No.
Okay, so you've come to us and you want to try the mouthpiece to...
Right, because yes, and another thing, I've had TMJ symptoms off and on since about 1986, 87.
Okay. Show the viewing audience how wide you can open your mouth. This is 28 millimeters. Get me a ruler. What's it show here today? Okay. 28. Okay, that's her maximum incisal opening. Now, bite down. See, she's got an 80% or more deep bite. Why these two clues were missed is beyond me. But this, I feel this TMJ problem is contributing greatly to her Parkinson's. Every Parkinson's patient I ever met has a TMJ problem. Okay, we're going to deliver her appliance a day or two from now, and then we'll monitor her progress as she goes along, and you'll be able to see her response. Do you still have trouble walking?
Well, yeah, when I get stiff because the medication isn't working, yeah, I have, when you're stiff, it's really hard to walk, yes.
Okay. How about today?
No, today I've been okay. My primary symptoms, even on off meds, are mostly from my neck up to my head lately. They've seemed to have changed since I had the DBS.
Okay. Today is the delivery appointment of this appliance. Notice the patient's deep bite and how the first thing the appliance is going to do is correct the deepness of the bite. Open. Bite. Now with the appliance in, you can see that the teeth do not overlap and the deep bite is gone. Tap up and down. Okay. This is the initial position we're going to leave the appliance in. We have balanced the appliance already and is hitting evenly on both sides. She has 1-point contact on the left and the right side in the upper first molar area against the flat plane on the left and the right sides of the lower appliance. We're going to see this patient in 3 or 4 days for her first checkup, and we'll show you the improvement between now and then. Okay, this patient returns after wearing her appliance for 5 days. We've adjusted it, and she just told me that for the first time last night she slept for 7 hours, which is highly unusual. She usually sleeps for 4 to 5 hours maximum, but now that her duration of sleep is starting to increase, which is a common thing that we hear from these Parkinson's patients. We'll see her next in 6 weeks from now, and we'll bring you her improvement at that time. This is a Parkinson's patient who's had her lower appliance for the past 6 weeks. She had a deep brain stimulator implanted. How long ago was that put in?
In October 2010.
And they've never been able to get the settings right on it, right?
Actually, up until a couple of weeks ago, that's true, but they finally got some good settings for me.
Okay.
And they're working really well in combination with the TMJ and everything else. It's starting to kind of fall together.
Okay, but When we gave you your appliance, they did not have the settings.
No.
Which is why you got the appliance.
Yes, at least, yes, partially.
Okay. And when we put the appliance in, you had hat band headaches 1 to 2 times a month
Yes,
for several years, and your big thing was insomnia, trouble sleeping.
yes.
And you, at that time, you could only sleep, what, 2 or 3 hours a night, or
4 or 5 maybe, and then I'd get up and it was like a split shift of sleeping.
okay, and now you're sleeping how much now
Sometimes 7, 8 hours.
a night?
Yes,
Let's see, you had facial muscle tightness. Your mouth opening has increased from 28 to 33 millimeters because we measured you today.
okay, that's great.
Yeah.
Every little bit helps.
Every little bit helps. You've had the Parkinson's, you've been on Parkinson's medications for 13 years,
Yes,
and now in the last month, they've just decreased your blood pressure medications,
yes.
right? Tell us about that.
Well, I was having really bad blood pressure spikes, which is associated with the time of the one dose of medication is wearing off and the second dose hasn't kicked in yet. And in general, I was on blood pressure medication anyway, but now they found, even though I'm having these spikes, my blood pressure is really low, which is common for Parkinson's patients. So now they have decreased the amount of blood pressure medication, but I still need some because my blood pressure does go up a little bit.
And this is since you got your appliance, right?
Yes,
Okay, and you've had these TMJ symptoms for years and years and years, but no one's paid any attention to them until we started a month ago. Is that correct?
well, yeah, I've complained to my doctors and nobody has really known what to do, and fortunately I found you and you seem to have a really good treatment program.
Okay. Well, it's nice that you said that. That was the right thing. Tourette syndrome is a neurological disorder starting in childhood and associated with involuntary repetitive movements, which are motor tics, and vocal sounds, which are called vocal tics. Tics are also classified into simple and complex tics. We hear over and over and over again that it all starts at 5, 6, and 7 years of age in these patients' histories. The reason for this is, I think, because the patients at this age are losing their teeth. And there is nothing that says the permanent teeth have to erupt in the exact same precise location as the baby teeth, which are being exfoliated. Many times the permanent teeth erupt in new or different positions which are not beneficial to the patient, and the normal maxillomandibular relationship, or the relationship of the mandible to the maxilla or to the base of the skull, is changed from one that is normal to one that is pathological. This is this young man's appearance from the front. This is his profile. Notice the verticalness of his upper lip and the receding lower jawline. This should tell you that his lower jaw needs to be brought forward. This is a picture of his teeth in centric occlusion. It should give you some idea of the deepness of his bite, approximately 50 or 55%, and his protrusion. This is a 9-year-old boy from California who was diagnosed with Tourette syndrome at 5 years of age by a neurologist. Many of these Tourette's patients are diagnosed at this young age. He gives a history of having had a bad fall at 2 months of age from his kitchen counter while being bathed and hitting his head on the tile floor. This is very common because a lot of mothers bathe their babies on the kitchen counter, and then the phone will ring or some other distraction will occur, and she turns around, and the child rolls over a time or two and then falls to the floor. We hear this story several times a year. He has 9 tics: eye blinking, which is one of the most common tics there is, throat clearing, coughing, arm extensions, jumping, skipping, and hopping, tensing of muscle groups, stomach tics, thrusting his groin or torso forward. And he comes in with approximately 8 tics, such as eye blinking, arm extending, jumping and skipping, hopping, tensing muscle groups, coughing, throat clearing, etc. Now look in the camera and show them some of these tics. Show them your head tics. Which, back like that. Do you have any mouth tics? No, okay. Like that. Okay, some more head tics. Like that. Okay. Now, how can you show us those stomach tics? Sitting or standing?
I can do both.
Okay, show them. Pull up your shirt. Okay. This is his stomach tic. You can see involuntary contraction of the abdominal muscles. Okay. And how frequent is this? Does this go on all day long?
No, not all day long. Okay. It just stops, like it like comes like probably for like 12 hours a day, and then at night it stops.
Oh, okay. So during awakening hours?
Yeah.
Okay. Now, can you demonstrate your skipping when you walk?
Yes.
Okay. Walk down to where your dad is and then turn around. Okay. And that's how you do it when you walk all the time? Okay. And how long has that been going on for?
I think since 3rd grade.
Since 3rd grade. What grade are you in now?
4th.
4th grade, okay. Okay, hop back in the chair. Okay. This young man returns after approximately 16 or 17 hours of wearing the appliance. You can see the relaxed muscles in his face. He reports that the majority of his tics have diminished except for his stomach tics. We increased the height of the appliance today to address that problem. This boy is 12 years of age, and his tics began at 5 years of age. He too was diagnosed by a neurologist, and he was diagnosed with Tourette's syndrome, myoclonic epileptic seizures, attention deficit hyperactive disorders, Asperger's syndrome, and acid reflux. His MRI is negative for disc displacement. That doesn't mean to me that he does not have a disc displacement in one or both joints. MRIs are only 74% accurate when they're negative and 92% accurate when they're positive. So even though the MRI cannot pick it up yet, that does not mean he doesn't have it. You have to make your decision on the clinical findings, not on the imaging findings. Other symptoms he reports are blurred vision in the morning, retroorbital pain, which is pain behind one or more eyeballs, photophobia, which means his eyes are sensitive to light. It is very, very frequently found in closed-locked TM joint patients. He complains of tinnitus, nose pain, neck pain, and back pain, pain at the vertex of his skull, numbness of his fingers, swollen lymph nodes since birth. He's got 35 tics, hopping, punching, kissing himself or others, twirling around, thrusting movements of the groin or torso, perches on his toes like a bird, sexually touches himself, sexually touches others, obscene gestures, breathing tics, self-injurious behaviors, makes animal-like sounds, stutters and voice changes, cracks neck, back, and chest. He also has eye blinking, head jerks, shoulder shrugs, tossing his hair, squinting, facial grimacing, nose twitching, throat clearing, grunting, sniffing, snoring, squeaking, laughing, touching objects, touching people, smelling fingers, smelling objects, jumping or skipping. This is a view from the right side showing a class 1 occlusion in the molar bicuspid area. This is his occlusion from the left side, again showing a class 1 dental occlusion. This is this boy's maximum interincisal opening, approximately 46 millimeters. For a person his age, the average in the scientific literature is 54 millimeters. This is a less than normal or impaired vertical opening. This is a 12-year-old young man from Seattle who presents himself for treatment. We're starting his treatment today by delivering an appliance. And you just look into the camera. He's got 35 different tics, from eye blinking, shoulder shrugs, head jerks, brushing or tossing hair, mouth opening, facial grimace, nose twitching, and so on. He's filled out a whole list of tics: throat clearing, grunting, sniffing, snorting, speaking, stuttering sometimes, twirling around, hopping, thrusting movements, etc. And you can see as he's going through some of these tics, and I haven't mentioned them all, that we want to eliminate them. He's 12 years old and he's in school, right? Yeah. And you're not aware of girls yet, are you?
No.
You will be.
Yeah.
Okay, if I fix your tics and you get too many girlfriends, I get your overflow, okay? That means the extra ones you send to me.
Okay.
Okay. Okay, look, you want to say something to the viewing audience? Anything at all?
No.
You just hope this works, huh?
Yeah.
And hopes it works darn quickly, huh? Okay. Well, I'm going to promise you it does, because we can help you out very quickly. And we're going to finish polishing up your appliance right now, which is in its final stages of fabrication. And then we're going to see it tomorrow. And we're going to film you tomorrow and the next day to show the improvement already. Okay? Good.
Okay.
We are putting this appliance in now, really for the first time, on this young man. Okay, Mike. Like that. And you can notice that it has an immediate effect on his tics. It just brings him to a screeching halt if you've chosen the right position and positioned it correctly. Okay. Now we're going to see this boy tomorrow. What time's your appointment?
9:45.
Okay. 9:45 will be about 16 or 17 hours from now, and we'll see the effect in 16 or 17 hours. Does that hurt you in any way or cause any problems, any strain? You think you'll be able to eat with it, sleep with it, talk with it?
Yeah.
If it makes you talk funny, which it probably does not, but if it does, you can practice reading out loud.
Okay.
Get yourself a newspaper or something and read it out loud. It is now 10 o'clock the following morning after the delivery appointment, and we have, the patient has been wearing this appliance for approximately 16 hours or so. And you can see that his tics are mostly gone. Tell the viewing audience what your experience has been.
It was good. I got really good sleep last night.
Speak louder, Steve.
I got good sleep last night, and I haven't ticked at all, really. So.
Okay, that's pretty good for less than one day. Do you want to say something? Come on back here. And, okay, this is this boy's mother, and she's going to comment on the improvement in the past 24 hours, or the past 16 hours.
Well, the first thing that I noticed was the calmness. There wasn't the ADHD symptoms. He seemed very focused, and obviously the tics weren't happening, which is like a miracle for us. He was almost like a different personality. He was very focused is a good way to say, and calm. I have never seen him so calm. And he slept so good last night. The hotel we're staying at, there's 2 queen beds. I didn't hear him ticking all night. I couldn't get him up this morning. It was like trying to get a sloth out of bed, which is not normal for him. He's usually bouncing off the walls. So it was really a miraculous turnaround in his life. I think it's going to change his life forever. So, yeah.
Well, that's excellent. That's a good endorsement. Good. You're doing all right. We're going to have to send you out to Hollywood. Okay, girls will be throwing themselves in front of your bicycle soon before we go back home. Okay, this boy returns for his first checkup. He's been wearing it 40 hours now, and you can see from his lack of movement that he's responding well to his treatment. His tics had returned a little bit, and we've made an adjustment this morning for him. Did you want to say something?
Not really.
Okay. How about you? You ready to say something? Do you want to say anything?
Okay, yeah.
Okay.
Yeah, it's definitely working. I can see already with the adjustment that he's returning to no tics and no ADHD symptoms again. So that's good.
This young man returns. He's been wearing his appliance 6 days now. And as you can see, his tics are totally gone. You want to say something for the viewing audience?
It's helped a lot.
It helped a lot. Speak louder. Speak louder.
It helped a lot, and I don't tick anymore.
Okay. You think you'll get a girlfriend now? Remember our deal. If you get more girls than you can handle, I get your overflow. Okay? That's the deal I make with all these young guys. It hasn't paid off for me yet at all. Come on back. Come out here. Why don't you say something?
This has just been a life-changing thing for Dane, and we're just so happy that we came and saw Dr. Stack. It was worth the trek from Seattle. And it's just been amazing to see like almost 0 tics, you know. He's just like a different child, and it's even lessened the ADHD symptoms, and he just seems calmer and more focused and able to just, I don't know, it's hard to explain, but he just seems really happy, and it's a lot better. It's changing his life. I can see where it'll help him in school too.
He's sleeping better?
Sleeping better. Oh yeah, it's hard to even get him out of bed in the morning. We were almost late for his appointment today.
Where before he wasn't a good sleeper at all, was he?
No.
No. And you feel he's had personality changes that are beneficial?
Absolutely, yeah. It's totally different. It's a different child.
He's nicer to have around now?
Yeah.
Okay.
He is. Not that he was terrible before, but he was feeling miserable before. And now this has calmed him down. You know, just feels more grounded, I think is a good word.
Okay.
Yeah.
Yeah, and focus too.
Yeah, definitely his help is focus.
Okay.
So.
Well, you go back to Seattle and tear him up there, okay?
Yeah. And we haven't seen, he hasn't had any seizures either. So.
Oh, he was having, what kind of seizures? Petit mal seizures? Epileptic seizures?
Myoclonic?
Myoclonic seizures?
No myoclonic seizures.
At all, in the past 6 days? Huh? And how frequently had he been experiencing those?
Probably all day long, every hour or so, or just little, you know.
Okay, well that's a benefit right there in and of itself. He's seizure-free now. Great.
Yeah. So thank you, Dr. Stack.
You're more than welcome.
Yeah.
Get on home, kid.
Yeah.
This is a young Tourette's patient with OCD whose tics began at 9 years old. He gives a history of head bumping, lip licking, vocal tics, throat clearing, shoulder muscles twitching, a feeling like he wants to explode, snorting, back arching, etc. This is the cephalometric x-ray for this young man, and you can tell immediately by looking at his soft tissue outline with his lower lip horizontal that he is overclosed. In other words, he needs an increase in vertical dimension. Also note that the mandibular borders of the left and right sides of the mandible are not parallel and superimposed over each other. One is higher than the other. That is indicative of shortening of the condyle up here in the glenoid fossa. This boy has a decent airway going for him, and he has no suboccipital compressed tissues. The first cervical vertebrae is supposed to be on a 45-degree angle, which it is. This is this man's left tomographic TMJ x-rays. This is initial contact, and this is wide open. And we make sure that the condyle translates out of the fossa, past the articular eminence, and is separated from it by at least 2 to 2.5 millimeters. We do not want the condyle touching the eminence. These are the right tomographic x-rays of this boy. This is centric occlusion here, and this is wide open. Again, we want to check the translation of the condyle to make sure it travels past the eminence and is separated from it by 2 to 2.5 millimeters. This is this young man's submental vertex x-ray, and it shows the mandible, which is outlined here, is not located in the center of his cranial base, but is displaced off to your right. You can see the difference between how much the ramus of the mandible is inset from the lateral surface of the skull on his right side and how it is overlapping the lateral surface of his skull on this side. The whole mandible is displaced to your right. What's your worst tic that you have?
My worst tic is probably right now it's probably maybe the lip licking. Yeah, lip licking tic. What it would make me do is make me move my lip up and rub the all the saliva on it, and then it gets dry. And then when it could last about maybe about a week, depending how much it
Show us how you do it. Okay. And you do that all the time? Or most of the time?
Mostly, once in a while it does it.
Okay. And you have a head bobbing tic?
Yeah, the head bobbing tic makes me during the 4th grade I didn't know that I had Tourette's when I had my friend over. We were in the backyard. I was by the fort, and I kept bobbing my head, and I was I kept bobbing my head like this, and it eventually started to kind of hurt a little. And I was like, he asked me, "What's wrong? What's wrong?" And I said, I don't know. I didn't know, and then eventually we found out that I had Tourette syndrome.
Okay. What other tics do you have?
Sometimes I have a certain kind of tic that like if I'm walking through maybe the mall or a grocery store, and it wants me to go like this and bob back.
Oh, okay. Do you have any shoulder shrugging tics or any other walking tics? Or?
I used to have a tic that would have me twirl around in circles in Target.
Oh, Target store.
Yeah, it would have me. It was during also the. It was during the 5th grade.
Okay.
That would make me just twirl around.
Twirl around. Okay. Okay. Well, today we took all kinds of impressions and X-rays on you to do our fabrication of your mouthpiece, which we're going to have ready for you in 2 days. We'll send it out to the laboratory tonight, and it'll be made tomorrow, and then we'll have it back the next day for you. Okay? Do you have any questions you want to ask?
No, not right now.
Okay, good. Okay. Tell the viewing audience what your hopes are for this treatment.
I hope that this treatment can help me. What I really want to do is go on classes with my friends. I hope this treatment will decrease the level of my tics. I hope that it will really put my tics down, and that I could learn a little bit more better, because the tics, they can really get in the way of your learning skills. So I wish I could so I hope that I could learn better, go around in public more, like I won't do much as tics as a lot. And I hope that this mouthpiece would succeed, and that I would be just like a normal person.
How are your grades in school?
My grades are good, really good.
Okay. Do you have to work extra hard to get good grades?
Yeah. A little bit, yeah.
Is reading hard for you?
Yeah, reading can be hard.
Yeah. Okay.
It's hard for me.
Okay. Let's leave it there, and we'll see you again when we put the appliance in for you.
Yeah.
One of the clinical signs that this patient was overclosed, or that his lower jaw was too close to his upper jaw, came on the lateral skull x-ray, which you see here. When the teeth are closed, the lower lip is supposed to be vertical, and as you can see on this patient's x-ray, his lower lip is horizontal. You can see this vast curve underneath the lower lip here. This should not be here. Whenever you see a patient's soft tissue appearing thusly on an x-ray, you can know that the patient is overclosed. Another way of saying this is that his chin is too close to his nose, and this dimension needs to be increased, which is one of the functions of the appliance which he will wear. Another clinical indication is that his overbite, or the amount of vertical overlap of his upper teeth overlapping vertically the lower teeth, is too great. It's 60%, which you will see later on in a frontal view of his teeth. It should be no more than 20% at the maximum. These are both indicators that he is overclosed and needs to have the distance between his upper nose and lower jaws increased. This young man's intraoral mouthpiece today. The question always arises, how thick do we make it, how tall do we make it, how high do we make it? And one way to do it is by putting in popsicle sticks or tongue blades and varying the height up and down to see what makes the tics go away. Right. We have done this on him and have determined that a height of 3 tongue blades drastically stops his tics. And so we are going to start with a height of 3 tongue blades initially for his mouthpiece. What we are going to do is mix up some acrylic, put it on this mouthpiece, and then have him close down on the soft acrylic till he reaches a height of 3 tongue blades. Open. You ready? Mm-hmm. I am loading the freshly mixed acrylic onto the mouthpiece, like so, and I'm going to put it in the patient's mouth. Open. Making sure the appliance is completely seated on his lower teeth. And then I'm going to have him close down, bite, until he closes down on the 3 tongue blades. Then open. going to have him open. And I'm going to take out the appliance. And then I'm going to put it in the cooker while it hardens up. And I'm going to trim off all the excess acrylic. Okay, we have adjusted the patient's appliance, open, and we are delivering it right now. And fitting it to his bottom teeth, right. Okay. Okay, now how's that feel? Yeah, hitting even? Yeah, okay. Good. Okay, look in the camera. Look in the camera. Okay. Now you're coming back this afternoon, right?
Correct.
Yeah. At what time?
I think like 1:45.
Oh, okay, good. That'll give him about 3 hours with it, then we'll do the final adjustment. Then you feel more relaxed or anything like that? Yeah, good. Okay.
You could notice a difference.
Say again?
You could notice a difference.
Mouthpiece has really helped. Really helped with just it has really improved that I'm not as taken as much. Like I would still have a few tics once in a while, but over time it will get better. And during the 3 hours, I was like hardly ticking, and it really helped. It really helped. It really did. I'm talking fun with it, eating fine with it. It's not hard at all. It's really easy to eat and talk with it.
Ken has had the mouthpiece for 3 hours now. And he's just come back here before he leaves town and for a quick checkup, and he seems to be progressing quite well. Okay, this young man returns after 4 months because he lives so far away. He's been under the care of another TMJ specialist out in his local area, and we rebuilt his splint today. Take a look and bite. You can see how tall we made it here. It's about 6 or 7 millimeters high. Don't be afraid to make them this thick. We made it this thick to compensate for the long intervals at which we see him for the wear and tear. And he's doing quite well. You can see he's lost all that discoloration around his lips, and his head movements have diminished greatly. In fact, they've ceased as he sits here in the chair, and this boy is responding very well, as he should.
It actually helped me really well when I just came in here. I was taking a lot more, and then when this got built up, I just really relaxed a lot more.
Tell him why you're in Washington.
Part of the reason why I'm in Washington is because I got elected for a Tourette ambassador program. I got elected for that, so I'm going to have 2 days of training over at the state capitol, so that's going to be a really fun time.
Okay. And you're going to be meeting members of Congress, right?
Yeah.
Good. Well, we've got a budding politician here. Why don't we have his mother say something? Why don't you look at the camera? Okay.
Hi, I am Kenny's mom. I'm Carla Richards. I was elected Mrs. Washington last year, and my platform was embracing the special needs child. And part of that, of course, is advocating for my own son who has Tourette's, which is why I met Dr. Stack after doing research and found out an alternative treatment for Tourette's. So we came here last November, and before we met Dr. Stack, my son, one of his large motor tics was doing circles down the aisles of Target, for instance, or he would jump back like he had a string pulling on his back, so it'd take a long time to shop at the grocery store. But he no longer has those large motor tics, so that has been a huge blessing. The challenge, of course, is just being able to keep up with follow-up appointments. And not everybody on the West Coast knows of Dr. Stack's procedure, so we are trying to educate them as well. So it just so happens we're killing two birds with one stone. My son got elected to represent the state of Washington at the National Tourette Syndrome Association Youth Ambassador Leadership Program. And my son and I, we also started a support group together, so he reaches out to the children and I reach out to the parents. Although he reaches out to the parents too and gives them encouragement. And so we're hoping after this training we'd like to go back and visit schools and educate parents, teachers, and students on Tourette's, how to advocate and empathy skills, and of course how to implement programs as far as the teacher's perspective, and of course to educate people about this alternative treatment as well. So we are very encouraged, and we're just taking it one day at a time, but so far everything's looking good. So just seeing him right now, it's a relief that I see him having some relief from getting an upgrade to his the level of